If you want to retain information and not just memorize it, you need a system that breaks things down for true understanding, all right? So go ahead and follow my 6-step framework and let's master urinary elimination together. Drop a in the comments if you're ready to pass your exams. Let's go. Step 1 is the patho breakdown. The urinary system filters blood to remove waste products and excess fluids, excreting them as urine while maintaining fluid and electrolyte balance like sodium and potassium. This function impairs waste removal and disrupts electrolyte stability. Step 2, risk factors. Risk factors for urinary dysfunction include aging, which decreases the GFR rate and delays drug clearance. Pregnancy, which increases the risk of postpartum urinary retention and urinary tract infections. Structural blockages like benign prostatic hyperplasia is neurological impairments. Step 3 is clinical manifestations and assessments. Assessment focuses on tracking voiding patterns such as frequency, dysuria, urgency, and urinary output. Normal urine is pale straw yellow, clear, and has a mild ammonia odor. Abnormal urine may appear dark or amber with dehydration, or cloudy with sediments and a foul odor when infection is present. Urinary retention presents with decreased output, bladder distension, constant urges to void, and overflow incontinence. While urinary incontinence is involuntary leakage of urine. Step 4 is diagnostic studies. Diagnostic evaluations include a clean cache urinalysis and urine culture collected before starting antibiotics when infection is suspected. Blood urea nitrogen, BUN, creatinine, and GFR evaluate kidney function, while a bladder scan measures post-void residual urine volume. Step 5, nursing interventions and pharmacological management. For urinary retention, perform a bladder scan, assist the client into a natural voiding position, and catheterize if spontaneous voiding is unsuccessful. For urge incontinence, medications such as tolterodine or oxybutynin helps to relax the bladder and increase bladder capacity. When caring for an indwelling urinary catheter, always maintain sterile technique during insertion. Keep the draining bag below the level of the bladder and off the floor, and empty the bag when it's about half full. Your interventions are effective when the bladder scan shows a low post-void residual urine output of at least 30 milliliters an hour in adults. Okay? The client reports relief of bladder discomfort and the urine remains clear without signs of infection. All right? Step 6 is patient teaching. So teach your patient with urinary incontinence to avoid bladder irritants such as caffeine, alcohol, and nicotine, and encourage regular Kegel exercises to strengthen the pelvic floors. Clients with chronic urinary retention should follow a scheduled toileting routine and practice double voiding to promote complete bladder emptying. For clients with indwelling urinary catheters or urinary diversions, teach proper hygiene, daily cleansing, and the early signs and symptoms of infection. So you know your teaching was successful when the client correctly demonstrates catheter clear or clean catheterization. They verbalize ways to avoid bladder irritants, follow a regular toileting schedule without skin breakdown or infection, and maintains a healthy pink to red stoma with a properly sealed pouch. Guys, stop overcomplicating your study sessions, all right? Using my 6-step framework will completely change how you master fundamentals content so you can finally crush your exams. And remember, I'm going to always leave you with this. Never dim your light for anyone. Stay lit.